Welcome to another episode from the Veterinary Medicine Digest. Today, we embark on an ambitious journey through the intertwined histories and modern complexities of mineral metabolism and endocrine disorders across veterinary and comparative medicine, examining everything from ancient diseases like rickets to modern equine syndromes and the molecular mechanisms of parathyroid hormone action. Let us begin with the historical foundations of bone health, centered on rickets, a metabolic bone disorder of young animals characterized by osteopenic changes resulting from the failure of newly formed osteoid to mineralize. Rickets was once a profound public health crisis dating back to Roman times. The ancient history of rickets. Descriptions of conditions consistent with rickets date back to antiquity. Soranus of Ephesus, a Roman physician around 120 Common Era, provided a notably complete text on newborn care, observing that if an infant was eager to sit up too early or stand too quickly, their spine and legs might become distorted because their bones lacked strength. Soranus's descriptions, along with those from Galen shortly after, suggest that rickets was commonplace, perhaps even typical, among Roman children. This high incidence was likely due to the combination of prolonged breastfeeding, often up to a year, and the common practice of swaddling newborns for the first few months of life, which prevented them from receiving necessary sun exposure. Later, imprecise reports of rickets emerged in the 16th century, citing texts from Holland in 1614 that might have referred to rickets under the titles ailment of St. Willebrod, where children had knobs on their ribs, and ailment of St. Macutus, where children had deformed legs. These descriptions suggest that the classic, ricketic rosary, was known at least 400 years ago. However, the medical understanding of rickets is generally dated from 1645, when Daniel Whistler described rickets and osteomalacia in his medical doctoral thesis. This was quickly followed by Francis Glisson's extensive Latin text in 1650, which was later published in English in 1668. The dual discovery of sunlight and oil. The initial breakthroughs in treating rickets came not from complex biochemistry, but from simple observations about environment and diet. The earliest person to connect deficient sunlight to the cause of rickets and advocate for its use as a cure was Jędrzej Śniadecki, a Polish physician and chemist. In 1822, Śniadecki advised that children should be taken out into the country and kept as much as possible in the dry, open, and pure air. If country air was unavailable, he suggested they should at least be carried about in the open air, especially in the sun, because the direct action of the sun on our bodies must be regarded as one of the most efficient methods for the prevention and the cure of this disease. He noted the frequent occurrence of rickets in densely populated towns where streets were narrow and the dwellings of the working-class people were poorly lit. Contemporaneously, British physicians found success using cod liver oil. Thomas Percival reported the use of cod liver oil for rheumatisms in adults and included a letter reporting its beneficial effect in 2 children with apparent rickets. By 1824, others had demonstrated that cod liver oil was effective in treatment. By the late 19th century, rickets affected a staggering 60 to 90% of urban British children, fueling controversy over its cause and proper treatment. Theobald Palm, a medical missionary, noted the high incidence in crowded urban areas of Britain compared to its absence in Asian countries, leading him to recommend sunbaths and relocating ricketic children from urban to rural environments. Furthermore, Buckles successfully treated ricketic children with incandescent light in 1904. The science advanced rapidly after the First World War. Edward Mellanby showed that fats, particularly cod liver oil, repaired bony defects in ricketic puppies, concluding that fat-soluble A was responsible for the anti-rachitic action. However, in 1922, Elmer McCollum and colleagues demonstrated that heat and oxygen inactivated fat-soluble vitamin A in cod liver oil, but did not inactivate the fat-soluble, calcium-depositing vitamin, thus showing that vitamin A was not the curative agent. It was quickly established that ultraviolet light could successfully treat rickets. Clinically, Alfred Hess noted that rickets had a seasonal variation, peaking in late March after children had spent the winter indoors, and showed that this heliotherapy increased circulating phosphate levels. The crucial link between sunlight and dietary supplementation was cemented in 1924, when research by Hess and Weinstock at Columbia University and Steenbach and Black at the University of Wisconsin showed that ultraviolet radiation of certain fats or plants endowed them with anti-rachitic properties. The use of filters established that ultraviolet B radiation, specifically between approximately 280 and 320 nanometers, was the active form of sunshine. This led to the successful policy of irradiating milk and other foods with ultraviolet light, nearly eliminating rickets. The material activated by UV light was eventually traced to the sterile fraction of foods, suggesting that light acted on a cholesterol-like molecule, known now as 7-dehydrocholesterol in the skin. The isolation and structural characterization followed, with ergocalciferol, or vitamin D2, being isolated from irradiated ergosterol. Finally, cholecalciferol, or vitamin D3, was prepared from irradiated 7-dehydrocholesterol. The antirachitic component found in cod liver oil was confirmed to be identical to vitamin D3, definitively closing the loop between fish oil and sunshine. The molecular era of vitamin D in rickets. The modern understanding of rickets and its treatment hinges on the elucidation of the complex metabolic pathway of vitamin D. Early clinical descriptions of severe infantile rickety disorders foreshadowed these discoveries. In 1937, Fuller Albright described a condition termed vitamin D-resistant rickets, which was resistant even to massive doses of vitamin D. Later, in 1961, Andrea Protter described a similar disorder that was sensitive to high-dose vitamin D therapy, which became known as vitamin D-dependent rickets. The breakthrough came when tritiated vitamin D3 studies revealed polar metabolites, leading to the identification of 25-hydroxyvitamin D3 as the main circulating form. Critically, between 1969 and 1971, several research groups identified calcitriol, or 1,25-dihydroxyvitamin D3, produced in the kidney, as the truly biologically active metabolite of vitamin D. This work established that vitamins D2 and D3 are first 25-hydroxylated in the liver to form 25-hydroxyvitamin D, the dominant circulating form, and then the kidney 1-alpha hydroxylates this molecule to produce the active 1,25-dihydroxyvitamin D. Protter's disease, vitamin D-dependent rickets, was subsequently identified as a defect in renal 1-alpha hydroxylation. The genetic defects involved in vitamin D metabolism were rapidly delineated. Mutations in the genes encoding the vitamin D25 hydroxylase, the 24-hydroxylase, and the 1-alpha hydroxylase were cloned in the 1990s. For instance, the principal human enzyme catalyzing 25-hydroxylation of vitamin D is microsomal CYP2R1. Mutations in CYP2R1 can cause a very rare, atypical form of vitamin D deficiency. Separately, the enzyme 24-hydroxylase, which inactivates vitamin D, was also cloned. Homozygous or compound heterozygous mutations in 24 Cypriot pounds A1 cause hypercalcemia, often leading to a diagnosis of idiopathic infantile hypercalcemia. These infants typically present with weight loss, failure to thrive, hypercalcemia, hypercholesteruria, and low parathyroid hormone levels, despite normal 25-hydroxyvitamin D concentrations. On the cellular level, Albright's 1937 work, though perhaps describing a different disorder now known as X-linked hypophosphatemia, is credited as the first description of vitamin D resistance. In the late 1960s and 1970s, evidence for the vitamin D receptor, or VDR, was found, which bound to calcitriol and associated with chromatin. In 1978, a report described a patient with symptoms suggesting end-organ resistance to calcitriol, leading to the name, vitamin D-dependent rickets type 2. The human VDR was cloned in 1988, and subsequent mutations identified soon thereafter are now recognized as the true cause of vitamin D-resistant rickets, which can classically present with alopecia. Parathyroid hormone, from mystery to molecular marvel. The parathyroid glands themselves were only discovered much later than rickets, escaping the notice of Renaissance anatomists until the 19th century. In 1852, Richard Owen first reported finding a small, compact, yellow glandular body attached to the thyroid, while describing the autopsy of an Indian rhinoceros. Later, in 1877, Ivar Sandstrom detailed the parathyroids in multiple species and confirmed his findings in 50 human cadavers. Early experimental parathyroidectomy in animals resulted in tetany and seizures, which linked the parathyroids to calcium metabolism. However, some investigators incorrectly suggested that the parathyroids functioned to restrain the thyroid. The roles were finally distinguished in 1909 when Berkeley and Beebe ameliorated human tetany with a parathyroid extract. The isolation of parathyroid hormone, or PTH, was achieved independently by Adolf Hansen and James Collop. Collop's superior preparation, marketed as parathormone, corrected tetany in parathyroidectomized dogs and caused hypercalcemia in normal animals. Collop's harsh acid extraction process resulted in PTH degradation into multiple peptides, but Howard Rasmussen later showed that only a small fragment, about 33 amino acids long, was active in raising calcium levels in rats. The full sequence of bovine PTH was reported in 1970. Today, teriparatide, which is the bioactive amino-terminal 34 amino acids of human PTH, is used to treat osteoporosis, although its use in children is avoided due to potential risks observed in animal data. The site of PTH action was a subject of vigorous debate between James Collip, who argued it acted on bone, and Fuller Albright, who insisted it acted on the kidney. Ultimately, both were correct. Furthermore, Albright is also credited with describing hormone resistance as a mechanism of disease when he detailed pseudo-hypoparathyroidism, which is now known to be due to heterogeneous GNAS mutations, rather than PTH receptor mutations. A vital connection was established when it was found that parathyroid hormone activates the expression of the mouse gene for 1-alpha-hydroxylase. This closed the loop, demonstrating how PTH regulates the synthesis of active vitamin D. We also recognize the existence of parathyroid hormone-related protein, or PTHrP, identified in adult malignancies causing hypercalcemia. While PTHrP shares homology with PTH and acts through the same receptor, its physiological role is generally autocrine or paracrine, rather than as a classic systemic hormone. A major physiological role for PTHrP is in fetoplacental calcium transport, suggesting it is principally a fetal hormone. The phosphorus revolution in FGF23. Our understanding of calcium and vitamin D metabolism revolutionized the treatment of rickets, but discoveries concerning phosphorus, the other major mineral component of bone, led to the finding of a crucial regulatory hormone. In 1937, Fuller Albright provided the first detailed investigation of hypophosphatemic rickets, characterized by renal phosphate wasting that proved difficult to treat with standard doses of vitamin D. He coined it vitamin D-resistant rickets. This descriptive term, however, is now considered misleading in the modern setting of X-linked hypophosphatemic rickets, or XLH, and should only be applied when the vitamin D receptor gene is mutated. True vitamin D resistance at the receptor level is not actually part of the pathophysiology of XLH. Early efforts to treat hypophosphatemic rickets involved high doses of vitamin D, which risked toxicity, or phosphate salts alone, which proved unsuccessful or refractory in children. In 1978, Charles Scriver established an important link by demonstrating that calcitriol, the active form of vitamin D, was impaired in children with hypophosphatemic rickets. Consequently, combining phosphate salts with high doses of calcitriol became the standard of care for XLH, though neither corrected the underlying renal phosphate leak. The search for the genetic cause of XLH led to the discovery of the PHEX gene, a phosphate-regulating gene with homologies to endopeptidases, on the X chromosome in 1997. However, the PHEX protein is expressed in bones and teeth and is not a humoral, circulating factor. The key to phosphorus metabolism was unlocked by studying a kindred with autosomal dominant hypophosphatemic rickets, or ADR. Persons with ADR showed similar biochemistry to XLH, hypophosphatemia, impaired tubular reabsorption of phosphate, and low or inappropriately normal calcitriol levels. Genetic linkage studies of ADR led to the revolutionary discovery of fibroblast growth factor 23, or FGF23, in 2000. FGF23 proved to be the long-sought humoral factor, made in bone, that controls phosphate wasting, fulfilling the characteristics of the hypothetical hormone, phosphatonin. The mutations causing ADR occur in a cleavage motif, resulting in impaired proteolytic cleavage and preservation of intact, active FGF23. Following this, other forms of autosomal recessive hypophosphatemic rickets, or ARHR, were linked to increased FGF23 expression due to abnormalities in 3 additional genes: DMP1, ENPP1, and FAM20C. Thus, high FGF23 expression became the common feature and driver of the biochemical consequences across these disorders. A critical connection was made in 2006 when Klotho was identified as a necessary cofactor for FGF23 signaling through FGF receptors. Klotho enables FGF23 activity, primarily in the kidney, and provides tissue specificity. Significantly, treatment with calcitriol and phosphate salts, the former standard of care, does not lower FGF23, instead, it stimulates FGF23 levels. Since FGF23 mediates the hypophosphatemia in XLH, directly targeting FGF23 is the logical next step. A targeted therapy, burosumab, an anti-FGF23 antibody, has been approved and shown to improve rickets in children better than conventional therapy. FGF23 is now considered the main phosphate-regulating hormone, secreted by osteocytes in response to active vitamin D and PTH. It promotes renal phosphate excretion by decreasing sodium phosphate cotransporter numbers and suppressing 1-alpha-hydroxylase activity, thereby reducing active vitamin D synthesis. Canine calcium and phosphorus disorders. In veterinary medicine, specifically in dogs, we see direct parallels to these historical human diseases. Rickets in young animals is characterized by the failure of mineralization of newly formed osteoid, resulting in osteopenic changes. Causes commonly include feeding a diet low in calcium, excessive phosphorus, or low vitamin D, or poor absorption of calcium due to impaired vitamin D metabolism or decreased availability. In a case study of an 11-month-old male nondescript dog, the patient presented with progressive bending of both fore and hind legs and difficulty walking, having been fed a regular meat diet. Physical examination revealed bending of the radius, angular tibia, and pain on palpation of the carpal and hock joints. Serum biochemistry revealed very low calcium and phosphorus concentrations, and high alkaline phosphatase. This condition, attributed to an abnormal calcium to phosphorus ratio common in animals fed all meat diets, results in angular limb deformity due to defective mineralization of the osteoid and cartilaginous matrix. Treatment included intravenous calcium gluconate, intramuscular vitamin D3, and a daily oral feed supplement containing calcium, phosphorus, and vitamin D3. The dog showed remarkable recovery and was able to walk with a normal gait after 6 weeks. In contrast to dietary rickets, dogs can also suffer from primary hypoparathyroidism, which is a failure of the parathyroid glands to maintain a normal plasma calcium ion concentration. Idiopathic hypoparathyroidism, often with a suspected autoimmune pathogenesis, results in hypocalcemic tetany due to insufficient parathyroid hormone secretion. In a study reviewing 6 dogs diagnosed with this condition, the clinical course was characterized by the abrupt onset of intermittent neurologic or neuromuscular disturbances. Owners frequently reported episodes of focal muscle twitching, generalized muscle tremors, cramping or tonic spasm of limb muscles, and a stiff, rigid gait known as tetany. In severe cases, episodes became progressively more frequent and violent, preventing the dogs from walking. Other signs included generalized seizures, ataxia, episodic weakness, and, in one dog, violent facial rubbing. Polyuria and polydipsia were also noticed in 3 of the 6 dogs. The diagnostic workup revealed severe hypocalcemia in all 6 dogs, with plasma calcium concentrations ranging from 3.9 to 6.1 mg per 100 milliliters. Serum phosphorus was high in 4 dogs. Crucially, the serum immunoreactive parathyroid hormone concentration measured in 1 dog was low, consistent with insufficient PTH secretion despite profound hypocalcemia. In 5 dogs, biopsy confirmed the diagnosis, showing marked atrophy and the replacement of 60 to 80% of the gland by mature lymphocytes, a lesion known as lymphocytic parathyroiditis, suggestive of an autoimmune pathogenesis. Initial correction of hypocalcemia requires slow intravenous infusion of 10% calcium gluconate solution, while long-term control relies on pharmacologic doses of vitamin D, with or without oral calcium supplementation. This high dose of vitamin D is required because the lack of parathyroid hormone diminishes the rate of renal conversion of vitamin D to its most biologically active form, 1-alpha-25-dihydroxyvitamin D. However, hypercalcemia, often with polyuria and polydipsia, was a common complication of treatment, occurring in 5 of the 6 dogs. When hypercalcemia occurred, adjusting the vitamin D dosage or eliminating oral calcium supplementation typically restored normocalcemia and resolved the polyuria and polydipsia within 2 weeks. Vitamin D supplementation in canine protein-losing enteropathy. Moving beyond primary metabolic defects, vitamin D status is also a significant concern in secondary conditions, such as canine protein-losing enteropathy, or PLE. PLE is a syndrome of excessive protein loss across a diseased enteric mucosa, frequently caused by chronic inflammatory enteropathy or intestinal lymphangiectasia. Dogs with PLE commonly have low serum vitamin D concentrations, referred to as hypovitaminosis D, which can occur with or without concurrent decreases in ionized calcium and secondary hyperparathyroidism. This hypovitaminosis is likely multifactorial, involving malabsorption, systemic inflammation, and direct protein loss. Notably, dogs with PLE and low serum vitamin D concentrations have been found to have a worse outcome compared to those with normal concentrations. A prospective, double-blinded, randomized, controlled clinical trial investigated the safety and efficacy of orally administered cholecalciferol, or vitamin D3, in dogs with PLE and decreased 25-hydroxyvitamin D concentrations. The study followed dogs receiving 400 international units per kilogram of cholecalciferol or a placebo daily, in addition to standard therapy for 6 weeks. The results showed that dogs treated with cholecalciferol had significantly higher 25-hydroxyvitamin D concentrations after 2 and 4 weeks compared to the placebo group. However, no difference in clinical or biochemical variables was observed between the two groups over the study period. For example, there was no difference in the canine chronic enteropathy clinical activity index score or serum albumin concentrations between the groups at any follow-up time point. A key finding was the strong positive correlation observed between serum albumin and 25-hydroxyvitamin D concentrations throughout the study. Conversely, no correlation was found between 25-hydroxyvitamin D and the vitamin D binding protein, which carries the majority of circulating vitamin D, suggesting the relationship with albumin might not be causal but related to the underlying pathophysiology causing decreases in both, such as intestinal lymphatic dysfunction or malabsorption. Importantly, approximately half of the dogs in the placebo group saw their 25-hydroxyvitamin D concentrations normalize after 4 weeks on standard therapy, suggesting that treating the underlying PLE disease process can lead to the resolution of hypovitaminosis D in terms of safety. Hypervitaminosis D, without ionized hypercalcemia, occurred in 5 dogs, or 18% of the study population, all of which returned to normal concentrations at the next follow-up. No dog developed ionized hypercalcemia during the study. Because some dogs developed elevated concentrations of 25-hydroxyvitamin D, the authors suggested a lower initial starting dose and close monitoring of vitamin D and calcium concentrations in dogs receiving cholecalciferol. Equine endocrine disorders, PPID and EMS. Shifting our focus to equine health, 2 major endocrine disorders often overlap: equine pituitary pars intermedia dysfunction, or PPID, and equine metabolic syndrome, or EMS. Equine PPID is one of the most common diseases affecting horses and ponies 15 years and older. Formerly termed equine Cushing disease, PPID affects the pituitary pars intermedia rather than the pars distalis. The pathological hallmark is hypertrophy, hyperplasia, and microadenoma or macroadenoma formation in the pituitary pars intermedia, leading to increased secretion of propionylmelanocortin peptides. Horses with PPID may have pituitaries that exceed 5 times the normal weight. As the pars intermedia expands, it compresses adjacent tissues and the hypothalamus, often resulting in loss of function in those areas. The active pars intermedia secretes large quantities of propionylmelanocortin-derived peptides, which may increase 40-fold in the plasma of affected horses. The pathology of PPID is critically linked to the loss of dopamine inhibition. Normally, dopamine released from paraventricular neurons inhibits the melanotropes of the pars intermedia. In horses with PPID, dopamine concentrations in the pars intermedia are decreased by 8-fold compared with controls, suggesting dopaminergic neurodegeneration. This loss of inhibition causes the melanotropes to undergo hypertrophy and hyperplasia, leading to the increased systemic release of peptides like alpha-melanocyte-stimulating hormone, beta-endorphin, and corticotropin-like intermediate lobe peptide. The clinical signs of PPID are varied and numerous. The most unique sign, considered essentially pathognomonic in an aged horse, is an abnormally long, curly hair coat that fails to shed, referred to as hypertrichosis or hirsutism. This may initially appear as slow or incomplete shedding, or hair retained along the legs or under the mandible. Another common and often early sign is weight loss due to muscle mass atrophy, although owners may miss this due to the horse developing a pot-bellied appearance. Despite this generalized weight loss, horses with PPID often have abnormal fat accumulations, especially in the crest of the neck, tail base, sheath, and supraorbital fossa, a pattern similar to that seen in horses with equine metabolic syndrome. Other signs include polydipsia and polyuria, secondary infections, lethargy, infertility, and sweating dysregulation. Equine metabolic syndrome, or EMS, is defined as a collection of risk factors for endocrinopathic laminitis. The central endocrine disorder of EMS is insulin dysregulation. EMS has a higher prevalence in certain breeds, suggesting a genetic basis. It is crucial to recognize that EMS and PPID are not mutually exclusive and can occur concurrently, influencing one another. Laminitis and management. Laminitis, a debilitating cause of lameness, is a major concern. Endocrinopathic laminitis, which occurs secondary to endocrine disorders like PPID and EMS, is strongly associated with increased basal and dynamic serum insulin concentrations, or hyperinsulinemia. Current data suggest that PPID is a comorbidity or risk factor, rather than the primary inciting factor, and that hyperinsulinemia is the catalytic factor for lamellar failure. In horses with concurrent PPID and insulin dysregulation, minimizing dietary non-structural carbohydrates is crucial to manage the risk factors for laminitis. Diagnosis of PPID often relies on measuring endogenous plasma concentrations of propionmelanocortin-derived peptides, such as adrenocorticotropic hormone. The preferred diagnostic test for identifying early disease is the thyrotropin-releasing hormone stimulation test with measurement of plasma adrenocorticotropic hormone, as thyrotropin-releasing hormone is a known physiological releasing factor of the equine pars intermedia. The preferred drug for treating PPID is pergolide, a dopamine agonist, which functions by decreasing the concentration of circulating propionmelanocortin peptides. Pergolide has been shown to improve both clinical signs and diagnostic test results. If a horse with PPID also has insulin dysregulation, medical management of PPID with pergolide typically improves insulin status. Treatment of EMS often involves managing obesity through diet restriction and exercise, alongside appropriate farrier care. For refractory obesity, levothyroxine sodium may be prescribed to reduce body fat mass and improve insulin sensitivity. For persistent hyperinsulinemia, drugs like metformin or canagliflozin may be used. Canagliflozin, a sodium glucose cotransporter 2 inhibitor, increases glucose loss in the urine, thereby decreasing blood glucose and reducing the amount of insulin secreted to maintain normal blood sugar levels. Equine mineral metabolism. In horses, calcium and phosphorus regulation exhibit distinctive features. Horses maintain high serum total and ionized calcium concentrations and have a high, often poorly regulated, intestinal calcium absorption. They also exhibit a high urinary fractional excretion of calcium and low serum concentrations of vitamin D metabolites compared to other species. Calcium is critical, making up about 1.5% of body weight, stored mostly in the skeleton as hydroxyapatite crystals. Extracellular ionized calcium concentrations are regulated by parathyroid hormone, calcitonin, and active vitamin D, working across the kidney, intestine, and bone, modulated by the calcium-sensing receptor. Parathyroid hormone increases when ionized calcium is low and phosphate is high, while calcitonin increases during hypercalcemia. A crucial imbalance disorder is nutritional secondary hyperparathyroidism, often called big head or osteodystrophia fibrosa. This results from diets low in calcium, high in phosphorus, or high in oxalates, particularly when the phosphorus to calcium ratio is 3:1 or greater. The condition remains endemic in many regions worldwide due to the ingestion of oxalate-rich plants. The pathogenesis involves excessive dietary phosphorus reducing intestinal calcium absorption, which also induces hyperphosphatemia. Oxalates bind dietary calcium to form insoluble calcium oxalate, further reducing absorption. Both low calcium and high phosphorus diets stimulate parathyroid cell hyperplasia and excessive parathyroid hormone secretion. Parathyroid hormone then increases bone resorption at the expense of skeletal reserves to maintain normal extracellular calcium concentrations. This bone loss leads to the typical and symmetric swelling of the facial bones, or big head, with excessive accumulation of unmineralized connective tissue, also known as osteodystrophia fibrosa. Treatment focuses on diet evaluation, eliminating grain-based diets, avoiding high oxalate feeds, and supplementing with calcium carbonate to achieve a calcium to phosphorus ratio of 3 to 4 to 1. Endocrine dysregulation in equine critical illness. Endocrine axes are profoundly altered during critical illness, especially the parathyroid hormone and vitamin D systems. Ionized hypocalcemia is a common finding in septic foals and horses with intestinal disease, often linked to insufficient parathyroid hormone secretion. Pro-inflammatory cytokines, elevated during sepsis, can contribute to this by activating the calcium-sensing receptor and decreasing parathyroid hormone secretion. Furthermore, hospitalized foals frequently exhibit hypovitaminosis D, with lower serum concentrations of 25-hydroxyvitamin D and active vitamin D, which are associated with disease severity and mortality. Of emerging importance in critical care is the FGF23 Klotho axis. In critically ill foals, disturbances in this axis have been documented, and those hospitalized foals with high fibroblast growth factor 23 or low Klotho concentrations were more likely to die. High fibroblast growth factor 23 inhibits the renal activation of vitamin D and promotes phosphate excretion. Klotho, as the co-receptor for fibroblast growth factor 23, possesses multiple protective properties, including anti-senescence and antioxidation. Parathyroid hormone. An old dog learns new tricks. Finally, let us consider the ongoing molecular research into parathyroid hormone's role in bone and metabolism. Approved in 2001, parathyroid hormone, 1-34, or teriparatide, was the first anabolic agent approved to treat severe osteoporosis. While chronic elevation of parathyroid hormone, as seen in hyperparathyroidism, leads to bone loss, the intermittent administration of parathyroid hormone stimulates bone formation greater than bone resorption. This short duration, known as the anabolic window, leads to increased bone mineral density and reduced fractures. The primary function of circulating parathyroid hormone is the precise regulation of extracellular calcium homeostasis. The hormone acts mainly on tissues with high expression of the PTH1 receptor, such as the bone and kidney. The skeleton acts as a critical reservoir for stored calcium, which can be acutely released when extracellular calcium levels are low, stimulating parathyroid hormone release. Parathyroid hormone does this primarily by signaling bone-forming osteoblasts to release receptor activator of NF-kappa B ligand, or RANKL, which drives osteoclastogenesis and bone resorption. Beyond its classical role in calcium regulation, a newly described and unique aspect of parathyroid hormone action is its regulation of cellular bioenergetics and metabolism, particularly in bone and adipose tissue. Bone formation by the osteoblast is an intensely energy-demanding process, requiring massive amounts of adenosine triphosphate to fuel matrix protein secretion and mineralization. Parathyroid hormone regulates this workload by promoting mechanisms for cellular energy production. Signaling pathways activated by parathyroid hormone, notably cyclic adenosine monophosphate and protein kinase A, regulate metabolism in osteoblasts. Research shows that parathyroid hormone promotes bone anabolism by stimulating aerobic glycolysis. Furthermore, bone-forming cells utilize fatty acids as an important substrate source for energy generation, in addition to glucose and amino acids like proline and glutamine, to enhance collagen synthesis. The mechanism often involves the phospholipase C pathway, which increases intracellular calcium flux. Once inside the mitochondria, calcium activates oxidative phosphorylation at multiple levels, ultimately supporting the high adenosine triphosphate demand of bone formation. Parathyroid hormone also interacts uniquely with adipose tissue. In white adipose tissue, parathyroid hormone administration stimulates lipolysis, or fat breakdown, resulting in glycerol and fatty acid release. This mechanism is thought to indirectly influence skeletal metabolism, as these fatty acids become available fuel sources for bone cells during periods of accelerated bone formation. Interestingly, parathyroid hormone can also alter the white adipocyte profile to that of a brown, thermogenic adipocyte, a process called beaging. This metabolic reprogramming enhances uncoupled mitochondrial activity. In the bone marrow, where communication between bone cells and precursors occurs, bone marrow adipocytes also express the PTH1 receptor. Intermittent parathyroid hormone treatment reduces the size and number of these bone marrow adipocytes by activating lipolysis, which is temporally related to a greater bone anabolic response. The fact that parathyroid hormone impacts metabolic processes across bone, adipose tissue, and even the kidney suggests a complex, systemic influence that goes far beyond simple calcium maintenance. These findings highlight a promising area for therapeutic development, particularly for treating musculoskeletal conditions like osteoporosis, by potentially reducing fracture risk through metabolic targeting. Understanding these complex mechanisms ensures that whether we are treating a dog with hypoparathyroidism, a full and critical condition, or an aged horse with endocrine disease, our approach is informed by both history and cutting-edge molecular science. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.